All right, thank you. I hope everyone can hear me. The microphone is working okay. I have the unenviable task of standing between all of you and lunch. I will try to keep this succinct. I see a lot of hungry people out there. We're going to shift focus a little bit from all of the talks this morning, which were about unimportant things such as arms and legs, and now focus on critical structures such as the spine. Specifically trying to clue everyone into which patients might benefit from spine surgery. Because as I had to tell Scott when he was hiring me, if you see a clinic of 30 or 40 patients in their 60s with hip and knee pain, a lot of them are going to need hip and knee replacement. If you see that same clinic of 60-year-olds with back pain, probably none of them are going to need surgery. So you have to be very specific and very narrow with your surgical indications to have good outcomes. But I will say that spine surgery in a patient who is well selected and a surgery that is well designed and well executed, spine surgery outcomes are just as good as hip and knee replacement outcomes. We are a stagger step behind the joint replacement doctors in terms of our technology. The hip and knee replacements have been around for 50 or 60 years. Our modern instrumentation has really only been around for 20, but it is just blossoming really in the last couple of years with new developments. First with pedicle screws, from the 80s and 90s, and then more recently with minimally invasive options and biological options that are able to enhance the carpentry that we do. And I'd like to pause briefly to thank, in particular, our corporate sponsors from spine surgery, DePuy Synthes, which is providing lunch, Medtronic and NuVasive. They each have a table outside, and I'd ask them to bring some of their implants for all of you to see and hold, so that when you, if you're a primary care doc and you see a patient who I have recommended surgery and that patient is now terrified, you will understand a little bit about what that surgery looks like. You'll have a chance to study the screws and rods yourself. And for those of you who are therapists, post-operatively, you'll get a sense of what motion-preserving surgery looks like versus fusion surgery. I, relevant to this talk, have no conflicts, unfortunately. This talk is in 2 acts. Sorry. The first half of the talk is focusing on the cervical spine, and then the second half of the talk on the lumbar spine. And these halves are essentially mirror images where we'll talk about degenerative changes, neck and back pain, then disc herniations in the neck and in the lumbar spine, and finally stenosis. And this really is a broad overview of degenerative spine problems, which is about 80% of the spine problems that I see, wear and tear type problems, ignoring completely the other 20% of spine problems that surgeons also take care of, including trauma, infection, inflammatory disease, and deformity. This is a degenerative talk, which is the majority of patients that I see and that all of you see as well. So when we talk about degenerative changes in the spine, there are joints in the spine that are unique compared to the rest of the body. Looking here on this x-ray, this is a normal spine. To orient you, this is the bottom of the skull. The jaw is over here, vertebral bodies, and the space, what appears to be an empty space in between each of the vertebral bodies, and that's where the intervertebral disc is. Those intervertebral discs can wear out, and then it looks like this, where the disc has collapsed down and lost its height, and that can be painful. There are also joints in the back of the spine, here. These are the facet joints, and these joints are essentially shingles, one on top of the other, that allow the little 8 degrees of motion that you see at each segment. And those also can undergo arthritis and cause neck pain. And here's a cartoon representation of what that might look like with a normal appearing spine and a degenerated spine where the disc has worn out, the facet joint has worn out, and caused pain. Sometimes, if that disc has worn out enough, you can get a disc herniation. This is what an MRI of a disc herniation looks like. To orient you, here's the bottom of the brain. This is the front, the trachea and the esophagus. Each of these white blocks is a vertebral body with a dark appearing disc space in between. The spinal canal is here. We're a little bit off center, so you don't really see the spinal cord, but spinal fluid appears white on an MRI, even though it's clear to yellow appearing in person. And you can see this bump right here, this dark bump, and that is a disc herniation. This is a cadaver specimen, not to gross anyone out too much just before lunch. This is bone right here, and bone right here. This is the intervertebral disc. And here you see a disc herniation, and that disc herniation is pushing against the spinal cord right here. When you have a disc herniation, the typical population is people who are essentially middle-aged in their 40s and 50s. And when the outer wall of the disc, or the annulus fibrosus, ruptures, is depicted here, this outer layer ruptures, the inner layer, which is called the nucleus pulposus, which is more of a gelatinous type material, can herniate outward. And in younger people, it's more of a soft, squishy substance. In older people, it might be a more calcified or bony substance, which is a, quote, hard disc herniation. So think of the disc almost like a jelly donut, where there's an outer layer that holds all the jelly inside. And if you have a fissure or a disruption of that outer containment, then the jelly can squirt out. When that happens, it causes pain by impinging on these nerve roots here. And it is a combination of the mechanical effect of the disc physically pressing on the nerve root, as well as an inflammatory response, cytokines released as a result of the disc material pressing on the nerve. And it's those two things in combination that cause pain. Typically, this type of pain comes on suddenly, like a thunderclap, and there will be a combination of neck pain, but also pain that radiates down the arm in a very predictable, or not always predictable, but a dermatomal distribution, depending on which level is involved. So the most common levels to get a disc herniation are in the lower cervical spine at C5-6, C6-7. When you get a C5-6 disc herniation, it affects the C6 nerve root, always the lower nerve root. So a 5-6 disc herniation affects 6, a 6-7 disc herniation affects 7. So C6 radiculopathy, meaning nerve pain radiating down the arm, is typically the thumb side of the hand. They'll get numbness, pain, tingling in this distribution. C7 is the middle finger, and C8 is the ulnar side, or the pinky side of the hand. And it can actually be somewhat difficult at times determining if this person has a C8 radiculopathy or if they have cubital tunnel syndrome, as Dr. Stanton was describing, that ulnar neuritis at the elbow, because it's the same area of distribution. Likewise, carpal tunnel syndrome and these fingers, C6 distribution. And the way you figure it out, of course, is by getting an MRI or potentially getting EMG and nerve conduction studies. But then you have the subset of patients who have an abnormal MRI and abnormal nerve conduction studies, and you're left trying to figure out which is bothering them, or potentially both, as a double crush phenomenon. Fortunately, the vast majority of people who have a disc herniation, and this is true in the cervical spine and the lumbar spine, the vast majority of them get better on their own. And that is because over the course of approximately 6 to 12 weeks, that disc material is resorbed by the body. So this gelatinous material that is sticking out and is pressing against that nerve root, your body has the opportunity to reabsorb that and return the contour of the disc back to normal, and the inflammatory response goes away. The problem is people have to wait for potentially 2 months. They're in sometimes agonizing pain. And so we do whatever we can to get them from time point 0 to the 6 weeks or 2-month time point with medical management. Oral steroids in particular are extremely helpful, like a Medrol dose pack. We can try steroid injections. And again, these do nothing to change the architecture of the problem. That disc herniation is still there, but we are masking the symptoms until your body has the chance to make the disc herniation go away. And 80% of the time, that's successful. The other 20% of people, the body will not absorb that disc over the course of approximately 2 months. And those are the ones that we would discuss surgery, doing a discectomy. In the cervical spine, there are two ways of, let me restate that. There is a more traditional way and a newer way of treating disc herniation. The traditional way is with an ACDF, or anterior cervical discectomy and fusion. The way that is done is the spine is approached from the front, so a small incision on the neck. The trachea and the esophagus are moved out of the way, and then you have direct access to the front of the vertebral bodies and the disc. You take the offending disc out, and once you've taken the disc out, you've relieved pressure on the nerve. And then you fill that space with some type of a spacer, and that can either be the patient's bone or cadaver bone or a specialized plastic material. And then you back it up with a plate here. And this is what an X-ray looks like. To orient you, this is the front, this is the back. The metal is white appearing on an X-ray. And this is one that has fused already, because you can see a very indistinct border between where the graft was and where the vertebral bodies are. So that is a successfully fused ACDF. And this is what Peyton Manning had in 2011. His first 2 surgeries, they did a little micro decompression from the back. It didn't work, of course. And then he eventually had this fusion in 2011. And since then, unfortunately, he's had a very successful football career. So it's extremely durable and has a very long track record. The problem is that this fails in 2 different ways. One mode of failure is that it doesn't fuse. And for a 1-level disc herniation, the rate of failure to fuse or non-union is slightly less than 5%. If you're doing a 2-level ACDF, as depicted in this cartoon, that non-union rate goes to about 10%. And then a 3-level ACDF, the non-union rate goes to 20%. There are ways of trying to help it fuse. If you have to do several levels, then you would put screws in the back to try to stabilize it and improve your fusion chances. But those non-union rates are not insignificant. The other mode of failure potentially is breakdown at the level above or the level below, and that's called adjacent segment degeneration. You can imagine that as a result of this fused segment, there's now abnormal biomechanical forces on the level above and the level below. When the level above and level below over years and years toggle more, then they may be at increased risk for getting another disc herniation at that level and needing subsequent surgery. It's actually controversial whether this person who blew out this disc is just genetically predisposed to blowing out this one because they picked their parents poorly and have bad genes for it, or is it because they have a fusion down here and created abnormal biomechanical stress? And the truth is, it's probably some combination of the two. As a result of those modes of failure, disc arthroplasty is catching on. And only in the last year or so has this been approved by insurance companies in Massachusetts. So where you probably weren't seeing really any of this a couple of years ago, I think you're going to start seeing this a lot more in the next several years. Disc arthroplasty is a ball and socket joint, almost like a hip replacement or a shoulder replacement. It's mobile, and you put it in the disc space after you've done the discectomy. And we have excellent short to intermediate term data, approximately 5 to 7 years, showing that, number one, neurologically equivalent in terms of relieving the radicular pain, Number two, the disc replacement does what it's supposed to do. It preserves motion at each segment of approximately 8 degrees. And number three, and most importantly, that the revision rate is lower in the short term. So at 5 years, if you look at the investigational device exemption study by the FDA for one of these early disc replacements, this one depicted here, at 5 years there's a 3% revision rate compared to approximately 11% revision rate for ACDF. So this technology is relatively new. The problem with disc arthroplasty is we don't have the same long-term horizon. So the majority of patients who have this problem are in their 50s. They're going to live another 40 to 50 years. And we know that hip implants, knee implants wear out at a predictable rate. We don't really know what happens to these inside a human 40 years down the road. So in a sense, ACDF is long-term reliable, but it has a short-term failure rate. The disc arthroplasty has excellent short-term data, and the long-term data remains to be proved. Shifting focus slightly to spinal stenosis. In the cervical spine, this essentially means the spinal cord is being compressed within the spinal canal. And what you can see here on this MRI that has a cartoon overlay to orient you, here's the spinal cord in the spinal canal. This is the bottom of the brain with the cerebellum. Trachea and esophagus are here in front. Each of these vertebral bodies is depicted by a cartoon, and then the discs in between. When there's not enough space in the spinal canal, that is called stenosis. And there are actually very precise measurements for how much stenosis is normal versus not normal. And relative stenosis measured on an X-ray is less than 13 millimeters. A certain percent of everyone in this room, 5–10% of you, have what's called congenital stenosis. You were born with a canal that is a little bit narrower than it should be. That may not cause a problem until later in life when you start to also develop some degenerative changes, the disc wearing out in the front, the facet joints wearing out in the back, and now that spinal cord, which didn't have very much wiggle room to begin with, is being encroached upon circumferentially. This is what stenosis looks like in an axial view and cross-section. Here's the disc. This is the spinal cord in this normal segment, no compression circumferentially. And here it's being compressed by disc in the front, facet joint arthropathy in the back, and ligamentum flavum centrally, circumferentially encroaching on it. And this is what an MRI looks like. Normal spinal cord. Here it looks like an olive, white appearing spinal fluid all the way around it, plenty of space, no encroachment. Compare that to this congenital stenosis. The roof of the lamina is a little bit narrower, more triangle shape, and there's not that white spinal fluid all the way around the cord. So symptoms of cervical stenosis can be insidious and difficult to pick up on. Some people have shoulder pain. They've seen the shoulder doctors for some time because it looks like a rotator cuff arthropathy. But they also get more subtle neurological deficits at first, and if this goes untreated, those neurological deficits can become quite profound. So be on the lookout for people complaining of balance problems. If you have people in their 60s and onward who have, of course, Walter, can I get you to? If you have people in their 60s and onward who have a lot of balance problems or unexplained falls, they're being worked up for things like multiple sclerosis, etc. It could actually be spinal cord compression in their neck or cervical stenosis. Also, they'll complain of hand clumsiness. They're having difficulty doing the buttons on their shirt or fine motor skills. They're dropping things. If they have a can of soda, it's sliding out of their hands. They're getting subtle weakness in their arms in terms of grip strength. Those can all be signs of spinal cord compression. If this gets very severe and goes untreated for long periods of time, people can get enough proximal muscle weakness in their arms and legs that they are relegated to a wheelchair because of quad weakness, and they get functionless hands and they get bladder incontinence. So untreated can be quite debilitating. The treatment for cervical stenosis, once it's detected and once there are symptoms, is surgery. This is an architectural problem. There is not enough space for the spinal cord, so no amount of medications, injections, physical therapy, etc. will improve upon that. And the natural history, as I had said, is that this is a stepwise progression of neurological decline. We like to catch them early because if you do surgery on that spine to decompress the spinal cord, you can't always get neurological function back. And the goal of surgery here is to halt the progression of the disease. So if someone comes in with weakness in their arms, you do surgery on them and a year later they say, "Doc, you didn't make me better." Well, as long as they're no worse, then that is a successful procedure. That is a win. 50% of people get some improvement neurologically, but it has to do with the duration of compression on their cord. If they're extremely weak, if they come to my office in a wheelchair, surgery's not going to get them out of the wheelchair because we can't repair the spinal cord. We can just decompress it and then give the spinal cord the best possible healing environment and see what happens. Traditional surgery for cervical stenosis with symptoms of myelopathy, so hand dysfunction, balance problems, proximal weakness, and potentially bladder and bowel incontinence, is a decompression and fusion. That decompression can be done in the front, as depicted here, with a corpectomy and a cage. That's essentially like a giant ACDF, taking the offending compressive structures off of the front of the spine. Or it can be done from the back. That's a laminectomy and fusion using rods and screws. And why you might pick one versus the other has to do with the nuances of that patient's anatomy. If they have a deformity where their head is tilting forward a lot in kyphosis, then this is a better option because you can essentially jack that spine back up to a normal lordotic alignment. If they already have preserved lordosis, then approaching it from the back is much more common. There's a new procedure, or at least relatively new, that's really taken off in the last 10 years or so. This is called a laminoplasty. Laminoplasty was developed in Japan, where there is a tremendous amount of cervical stenosis, partially because people live a long time, and partially because they have a lot of OPLL, ossification of the posterior longitudinal ligament, which is one reason that you can have spinal cord compression. Instead of doing a traditional fusion procedure, which takes away motion, this is motion preserving. At every single level, you put in a little plate like this, which essentially opens up the spinal canal like this, and then holds that canal open. This is what an X-ray looks like right here with these little plates at every level. Although those plates appear flimsy and they're actually malleable, they don't break or wear out because they're not crossing a motion segment. So unlike trying to heal a fracture where you're trying to prevent any motion from happening, there really isn't motion across here. You're just holding the door open. So those small plates do a very good job. These two options, the newer laminoplasty versus the older fusion techniques, are also neurologically equivalent in terms of improving or halting the progression of cervical spondylotic myelopathy. And the laminoplasty preserves motion and doesn't rely on fusion biology. So some % of these patients are going to fail to fuse and then they need another surgery. Laminoplasty avoids those problems. So it's a very good option catching on. Reasons why you can't use laminoplasty in some people: if they're tilted forward already in kyphosis, then opening up the spinal canal will not adequately decompress the spinal cord. They have to have a normal curvature to their cervical spine. If they have a lot of neck pain from facet arthritis or disc degeneration, that also is not a good candidate because they're still mobile, so they'll have persistent neck pain. Shifting focus from cervical spine to lumbar spine. Lumbar spine degeneration happens through a cascade of events. Here we're looking at the intervertebral disc. Up top, this is a normal appearing intervertebral disc. A bone above, bone below, the outer annulus fibrosus and the inner nucleus pulposus. So that's what a disc appears in, like in a younger person, a teenager. When the disc starts to degenerate, it's not quite the same as arthritis because it's not really a cartilage joint, but in principle it's very similar. When the disc degenerates, it loses some of its height, it dries out or desiccates, and it loses its normal architecture. So here's what my discs probably look like. Stanwood, Zabilski, Oliver. These discs have lost their height and collapsed down. It is dried out, and this is why our geriatric patients will notice that they've lost an inch or two of height over the years. It's because at every single level, this disc has squished down a little bit. Here's a cartoon representation of those discs squishing down. More normal appearing, preserved height, abnormal appearing, loss of height. You can also get degenerative changes in the back with the facet joints. The facet joints are more similar to other joints in the body, such as knees, wrists, etc., where you have a cartilage joint, and that joint can undergo arthritis and become very painful. The vast majority of back pain comes from multiple different places in the back. And the reason why spine surgery is not particularly effective for most back pain is because it's not coming from just one spot. If we could be absolutely sure prior to surgery that this one joint was the bad actor, then fusing that joint would make the pain go away. But in most people, they've got joints at every level, plus their discs, plus their SI joints, plus they have fibromyalgia, plus they have anxiety and depression, and all of those things go together, and that's why surgery for back pain is not particularly effective. You do find the occasional person, typically a younger person, that has one dark disc. It looks like the bad actor. The rest of their spine looks normal. They're psychologically normal, and they're desperate to get back to work, and they can't. In that subset, spine surgery for back pain may be helpful, but in most people, you can't cut away all of their pain, so they're not satisfied with the result. This is what a normal appearing x-ray looks like here. Well-preserved disc heights at every level. Normal curvature or lordosis. And here's a degenerated one where the disc has lost its height. You get these osteophytes out in front, kind of look like barnacles. And that's the body's attempt to stabilize the spine. As the spine is degenerating, those facet joints in the disc space can become a little bit more mobile, and the body tries to protect itself by stiffening up a little bit. And that's why you get these funny growths in the front. If those degenerative changes are bad enough, you can have compression on the nerve root. So here's the disc in the front, the facet joint in the back. When that facet joint becomes arthritic, it can expand a little bit. When the disc collapses down, sort of like squishing a Coke can, if you collapse it down, it bulges out, and then you get that circumferential compression. When the disc annulus wears out, just like in the cervical spine, in the lumbar spine, that nucleus pulposus or gelatinous material can herniate out, press on a nerve root, and cause pain. And again, it's the combination of the mechanical pressure as well as the inflammatory cytokines that are irritating that nerve root. And again, happening to people in their 40s, 50s, that soft disc material squishes out. It feels like a thunderclap of pain all of a sudden. They may have been minding their own business and doing nothing, or they may have been involved in some physical activity. And typically it's a combination of back pain as well as leg pain in a very particular distribution. The most common levels to have a disc herniation in the lumbar spine are at the lowest levels, which are the most mobile segments. So L4-5 and L5-S1, and that's why typically you get lower leg problems. This is what a disc herniation looks like on MRI. Here's a nice normal appearing disc. It has a darker annulus on the periphery, but then a lighter appearing nucleus pulposus in the center. When that disc degenerates, it darkens, it collapses, and here this disc is herniated out, causing pressure on a nerve root. Here's the distribution of pain and numbness and weakness that we typically see. Depending on where that disc herniates, it can either squish out farther to the side, or it can squish out more centrally, and that dictates which nerve is most involved. But you'll often see a very classic L5 distribution, so they'll say the outside of their calf is killing them, or the back of their leg, bottom of their foot is killing them. But I will say for both cervical and lumbar disc herniations, once these nerves leave the spinal canal, they all crisscross, and the traditional brachial plexus pattern that we all had to memorize and lumbar plexus pattern, which some of us memorized and most of us didn't, is only true for about 60% of us. So it's not that uncommon to see, for example, an MRI with a C5-6 disc herniation, which should cause C6 symptoms, thumb side of the hand symptoms. However, they just seem to have C7 or C8 symptoms, and that's because of all of the crisscross in the brachial plexus or in the lumbar plexus. So don't be surprised, that happens about 20% of the time. There are approximately 150 different described variants of the brachial plexus. The commonest type that we all memorize is only about 60% of the time. So for disc herniations, as in the cervical spine, in the lumbar spine, we try to wait them out. We give them steroids. Oral steroids are very effective for this. We do injections in the spine, and that injection bathes the area in anti-inflammatory and numbing medication, which helps get them out to the 6 to 8 week time point so that their body has the opportunity to absorb that disc material and go away on its own. And sometimes you'll see a very big disc herniation either in the neck or in the low back, and I get a call from one of the providers who sees a monster disc and they're worried about it because it looks like it's squishing the spinal cord and going to paralyze someone. And it's concerning to see it, and if you have the stones for it, you wait them out and then they get better. About 20% of people don't get better on their own, as in the cervical spine. In the lumbar spine, you wait them out, they're miserable for a while, but the 20% that don't get better on their own, you do surgery, and essentially that surgery is to take the pebble out of their shoe. That's a microdiscectomy. You make a small bone window in the back, in the lamina. You push the fecal sac out of the way, and the nerve roots are out of the way, and then you're able to access that disc herniation. And it kind of looks like crab meat when you take it out, and you just pluck the herniated material out. This does have a chance of recurring. We've tried in the past various ways of preventing disc herniations from happening a second time once we've been in there to take out the disc material. We've tried various glues, suture materials, etc. It just doesn't work very well. The intervertebral disc has a very poor blood supply, so it doesn't heal. And so all those attempts that we'd made in the past to fix that defect fail. We just have to accept that some people will reherniate their disc, in which case we wait them out again. If it fails, we take the disc material out again. And if 3 strikes or sometimes 4 strikes, we'll actually fuse that segment to prevent the disc from ever coming out again. This is all done through a microscope, very small incision, same-day surgery. People are leaving the hospital on the same day. Lumbar stenosis is a little bit of a different animal from cervical stenosis. So cervical stenosis is always a surgical problem once they start having symptoms, because the spinal cord up in the neck doesn't take a joke very well. Once that spinal cord is compressed, you have profound neurological problems that do not get better even after you take the compression away. In the lumbar spine, remember your spinal cord ends at approximately T12L1. So really in your mid-back, your spinal cord ends. And below that, it's all nerve roots. And those nerve roots are much more tolerant of compression. That's why we're able to push them out of the way to do our discectomy, where we would never ever push the spinal cord out of the way in the cervical spine because we'll paralyze someone. In the lumbar spine, you can push those nerve roots aside safely and they're fine. In lumbar stenosis, it is again not enough space in the spinal canal for all these nerve roots. Circumferential compression of the fecal sac from the arthritic facet joints in the back, the disc in the front, and the ligamentum flavum in the back. But these people, we can wait them out a little bit, and when I see them in the office, I tell them that this problem is more like arthritis in your hip or arthritis in your knee. This is typically a quality of life problem. It usually does not leave people with significant neurological deficits, although it can in the most severe form, but it mostly causes leg pain. This is what an MRI looks like. Here's a normal spine. Outlined in yellow is the space available for the nerve roots. This is the intervertebral disc. This is the lamina and spinous process in the back. Each of these little black dots here is an individual nerve root, and those nerve roots exit at every section, at every segment. Surrounded by white spinal fluid, no compression on the nerve roots. Compare that to this MRI, outlined in yellow. This is what stenosis looks like. Those nerve roots are extremely crowded circumferentially by the facet joints and the disc and the ligamentum flavum. Sometimes, as a result of the degenerative process, you have not only crowding of the spinal canal, which is stenosis, but you also have a component of instability. When these facet joints in the back become very degenerated and arthritic, they can become mobile, as can the disc in the front. And when you have enough instability, then you can get one vertebral body slipping forward on another vertebral body. That's called spondylolisthesis. Essentially, one vertebral body slips forward like that. If you think of the spinal canal like a tube, and we're looking down the tube like this, if that spinal canal gets shifted, all of a sudden the space available in the center of the canal is decreased, and that causes spinal stenosis again. The treatment for stenosis, if they have failed conservative management, meaning you've tried physical therapy for core strengthening, you've tried injections, you've tried medications, they've lost weight, they've done all the right things. Treatment for spinal stenosis with neurogenic claudication, meaning leg pain when they walk, is a decompression procedure. I'm sorry, here's what the nerves look like as they come out of the spine. They coalesce into the important nerves going down your leg, such as the sciatic nerve, and that's why compression in your lumbar spine causes leg pain. So if there's no instability and the problem is only from compression, then the treatment is to just decompress that segment, and that's most commonly done with what's called a laminectomy. That just means removing the roof of the spinal canal. So if the spinal canal kind of looks like a circle, you just take off the top. And that effectively decompresses the thecal sac and the nerve roots by removing the roof. However, if that patient has instability in their spine, meaning not only is their canal compression, but there's also a mobile segment, one vertebral body has slipped forward on the other. If you do just a laminectomy for those patients and you take off the roof, then you are destabilizing the spine farther. So they will slip even more after the laminectomy has been performed. The problem with that is that these little holes here, that's called the foramen, that's where the nerve roots exit. And you can imagine if this vertebral body slipped forward on this vertebral body, this hole becomes much smaller and you have nerve root impingement as a result of that slip. That's why patients who have stenosis with instability benefit from a fusion procedure to prevent that slip from worsening. This is what a fusion looks like. There are screws that go through the pedicle, creatively named pedicle screws, and these are held together by these rods. There are other new modalities that can be used to help the fusion happen, including these spacers in the disc in the front, various biological agents, and we're now getting fairly adept at approaching the spine, not just from the back, which was more traditional, but also minimally invasive approaches from the side and from the front. So modern spine surgeons are comfortable approaching the neck, the thoracic spine, and the lumbar spine from any direction. That ends my prepared remarks. What I'd like to leave all of you with before lunch, and my parting statement is, I think we have the opportunity down here to build a spine program that is second to none. And that is a collaborative effort between all of us. We have an excellent spine center at the hospital that is non-operative management for back pain. And they're able to take care of our back pain patients who don't need surgery. It's a place for me and for all of you to send non-surgical candidates. And they've become very academic in their approach to back pain. We now have some enhanced surgical capabilities. And an area that, as a growing population of the right age, people in their 60s, 70s, and previously not as much spine care available. So my hope is that we will catch up with the spine program in the next 5 years or so. We'll catch up to the joints program. The same types of pathways that are in place for hip and knee replacement in terms of quality of care measures that can be done for spine as well. And I think that's important. And I want to bring all of that in. And that is a collaborative effort between me, the other surgeons in my group, and really all of the providers here, the primary care docs, the physical therapists, and everyone. So thank you for your attention. Enjoy lunch, and take any questions. Yes?